Dude, I thought you guys hated me.
Good morning, everyone. We're giving folks just another second to join. Good morning and good afternoon, everyone. My name is AC Locklear, and I am the CEO for the National Indian Health Board. Thank you all for joining us for our 2025 Tribal Health Week webinar. Before we jump and get started, this webinar will be recorded. If you do not wish to be recorded, please drop from the call at this time. Wonderful, great. Well, welcome again to Investing in Tribal Health, a webinar on strengthening public health for future generations. Next slide, please. Today, we'll be joined by many of our team members here at the National Indian Health Board. These are just some of our team members. Myself, next slide. We'll be joined today by Lacey Wynn, our Director of Public Health Policies and Programs, Wynn Davis, our Director of Congressional and Interim Director for Federal Relations, and Rod Jacobs, our Director of Development and Strategic Engagement. So we're going to start today's agenda with an overview of the National Indian Health Board, and I will provide a state of Indian health. Then we're going to jump into protecting and advocating for the federal trust responsibility, followed by healthy landscape and activities in Indian country. We're going to discuss the 2025 National Tribal Health Conference, as well as pathways to partnership and investing in tribal health sovereignty. So we're going to jump in to talk a little bit more about the National Indian Health Board. So the National Indian Health Board was established by tribal leaders 50 years ago to advocate as a national united voice of federally recognized American Indian Alaska Native tribes. National Indian Health Board, or NIHB for short, seeks to support and reinforce tribal sovereignty, ensure fulfillment of the federal government's trust responsibilities and treaty obligations to tribal nations, and strengthen the government-to-government relationship between federal governments and tribes across the nation. Our work is dedicated to continually advancing these canons in support of Indian healthcare and public health in tribal communities, and educating and reinforcing how these canons apply across the entire United States government. Next slide. I think you skipped one. Other direction. There we go. The National Indian Health Board is comprised of 12 member organizations representing each of the 12 IHS regions. These member organizations are area Indian health boards, and our board is comprised of a tribal leader from each of the areas. This is why the National Indian Health Board is a tribally led organization, and we answer to the 574 plus tribes that founded this organization. Next slide. And we approach our work from a tribally driven agenda. These are some of the pillars of that agenda, as we discussed, honoring trust and treaty and government-government relationship, achieving equitable and comprehensive funding for Indian health, building innovative and sustainable health infrastructure across Indian country, promoting improved and equitable health outcomes for Indian country, improving access to behavioral health in tribal communities, supporting an empowered and culturally informed workforce, increasing access to quality health care, and strengthening tribal public health capacity and infrastructure. And we take a variety of approaches to achieve these pillars. We advocate for effective health policy regulation legislation. We do a lot of policy formation and analysis, training and technical assistance and capacity building, programmatic support. We work across the administration and as well as Congress and legislative and regulatory tracking. We communicate with tribes and provide educational resources on policy and other public health issues facing Indian country. We help to build tribal capacity, and we facilitate engagement with federal agencies for tribes. Next slide. Now we're going to jump into the state of Indian health. As you know, there are over 574 federally recognized American Indian Alaska Native nations residing on 334 reservations across 35 different states in the United States. There are diversity of needs and a diversity of health outcomes and issues facing Indian country. Each tribe, their lands, and their culture all are factors depending on the needs of that the needs of that community. Next slide. All of these tribes have a trust responsibility and a relationship with the federal government. So one of the things that we in IHB do is we work to ensure that the federal government lives up to this trust responsibility. And that is to fulfillment. It's a legal obligation to ensure the highest possible health status for American Indians, Alaska Natives, and urban Indians, and provide all resources necessary to affect Indian health. Next slide. Unfortunately, we see declining health outcomes across the United States for American Indians, Alaska Natives. Right now, American Indians, Alaska Natives have the lowest life expectancy of any population in the United States. Currently, the life expectancy in 2021, the life expectancy for American Indians, Alaska Natives went down 6.6 years. This is unprecedented and devastating hit to our population. This means based on current health patterns, our people born today, our children, our babies are only expected to live to be 65 years. And that's average. In some areas, it's much lower. So in other words, our children are not expected to live long enough to even qualify for Medicare. Next slide. Declining health disparities is a chronic issue in Indian country, but as to is severe underfunding of the tribal healthcare system. Recent federal budget cuts, including to reductions in programming and funding, threaten the stability of tribal healthcare systems that are already chronically underfunded, with IHS receiving only about $8 billion for fiscal year 25, which is far below the recommended need. Many clinics are facing staffing shortages, reduced services, and potential closures if there are any further losses to funding for Indian health. There have been proposed cuts to Medicare and Medicaid. Please go back one slide. Thank you. Proposed cuts to Medicare and Medicaid that could really undermine and decimate our current tribal health systems. Tribal health relies on Medicare and Medicaid funding. Tribal facilities often receive about 30 to 60% of their revenue for American Indian communities from Medicare and Medicaid. Any reductions to Medicare and Medicaid would lead to service eliminations, layoffs, increased medical debt for our populations, and would increase health disparities. NIHB is currently advocating and continues to advocate for full and mandatory funding for the Indian health system to address the chronic underfunding that leaves tribal health systems unable to meet community needs effectively. We also collaborate across sectors in response to many of these issues that are facing Indian country. Most recently, the National Indian Health Board was a founding member of a national tribal coalition group, which is focused on fostering collaboration among key organizations such as NIHB, the National Indian Education Association, the National Finance Officers Association, the National Congress of American Indians, the Urban Indian Health Organization, as well as others. This coalition works to address systemic challenges in areas like health, education, economic development by pooling resources and expertise to advocate for our communities. Next slide. This coalition group has provided an opportunity to share resources for tribal advocacy. Most recently, we've created a centralized website that isn't tied to any specific organization as a place for all of us to provide our resources that tribes need to address many of the issues facing tribes due to the recent changes in administration. These include federal agency memos, congressional communications, and advocacy tools. This hub empowers our tribal leaders to navigate policy changes effectively and advocate for their communities in the ways their communities need. We also at NIHB emphasize that achieving the greatest level of health requires respecting tribal sovereignty. This involves ensuring tribes lead in designing culturally relevant health solutions that reflect their unique traditions, languages, and priorities. Through initiatives like the 2025 Tribal Data Health Symposium, NIHB is advancing tribal data sovereignty by addressing barriers to federal data access and empowering tribes to take their own health narratives. This includes building tribal data infrastructure and workforce capacity. And despite systemic challenges, tribal nations continue to demonstrate resilience by integrating traditional practices into public health programs and innovating solutions for chronic disease prevention, maternal health, and more. Next slide. Now is a moment, perhaps unlike any other in tribal health, a moment where there are more eyes and ears on our community than ever before. It is a moment for our people to show their support louder than ever before. It is a moment for supporters, large and small, to show their support financially. Our work has already changed the tide, like the HHS advisory opinion exempting tribes and tribal programs, largely influenced by NIHB's efforts. But we must continue this momentum. You'll hear more from our team at National Indian Health Board about the work we are doing for Indian health. And at the end, we'll share the ways that you can support us and Indian health. I will now pass it over to Wynn Davis, our Director of Congressional and Interim Director of Federal Relations.
Thank you, AC. So we're going to discuss protecting and advocating for the trust and treaty responsibility. And I'm going to try and provide kind of an overview of what our government relations department does, who we work with, and kind of the important driving factors behind the work that we pursue. Next slide. So as AC described, our entire organization works with the 574 plus federally recognized tribes, and our board is made up of 12 individual members that come from the area Indian health boards. We work with those area Indian health boards and our board specifically to get direction on what we're going to be working on over a particular year. And so that begins every year with our legislative and policy agenda. That happens very early in the part of the year. It's an extensive 22-page document. We're in the process right now of finalizing our 2025. That will be available on our website. If you have interest, our 2024 legislative and policy agenda is also currently on our webpage under our government relations page. And that outlines the areas where we focus our work, and it elevates the priorities of tribes and tribal leaders across the country when we work with the departments and agencies in the federal government. So who are we working with specifically? Next, go back. Thank you. Next, go back. Thank you. So who are we working with specifically? We work with federal partners. So when we say that we're working on something with federal partners, we're working across the entire federal level. So that means that we're working with Congress, we're working with the executive branch, and we're even working at times with the judicial branch when particular policies are being litigated and may have an impact on the way that healthcare is delivered to Indian country. We additionally work beyond with tribes with other organizations that work to serve and deliver health through tribal organizations, tribal advisory committees that are established either in statute or as a part of the advisory process laid out under the Federal Advisory Committees Act to support agencies within the Department of Health and Human Services. We're also working with other stakeholders and advocates, particularly academic, state, and private fund partners who are working to advance the mission of Indian Health. As a part of the way that we deliver this messaging to our federal partners and how we help bring that information out into Indian country, we frequently participate in drafting of talking points for tribal leaders when they're having specific engagements with federal partners. We work on letters, we work on template letters, we work on template resolutions, we work on resolutions that our board adopts, indicating our positions. We also work specifically on legislation. So we'll either provide feedback on legislation or we'll provide drafted legislative text for issues impacting Indian country. And then we do a whole set of work related to budgets. Right now, we're currently working on the FY27 tribal budget recommendations. That book will be available when we go to the HHS annual tribal budget consultation in about a 2-week time period. This is an extensive process that begins kind of at the beginning of the year, and it runs for a full year cycle as we work towards the development of those budget recommendations, and then that culminates in the spring when we publish that. But beyond that work that we do, we're also currently working with the Robert Wood Johnson Foundation on the development of a full funding estimate beyond the budget recommendations that takes into account all of the different pieces of the delivery of Indian health. And so we can have a very full picture of what it means when we say that the Indian Health Service is deeply underfunded, so that we can provide information to Congress and to our partners. We also work specifically to set up meetings for tribal leaders to help bring folks together with government partners to have those important conversations. We work on hearings, we work on Hill briefings. We also work very extensively to deliver Hill visits to create the space for tribal leaders to come in and have those conversations. Next slide. And so what are the areas that we really are working in? So it's creating a space for that united voice of tribes. We work relentlessly to bring tribal rights for consultation to the fore. Our relationship with the federal government requires that we be engaged on the front end and not on the back end, so that we work to make sure that we're a part of that conversation and not an afterthought. Because HHS is so large, we actually work across one of the largest portfolios related to policy in the federal government, because there are so many different agencies and programs within HHS. Tribes work across almost all HHS programs, even when there are not specific tribal set-asides in those programs. And to provide an example of that, tribal facilities that are owned and operated by tribes, while they may have a certain amount of funding that comes from the Indian Health Service, they may also participate in other grant programs like HRSA's 330 program for federally qualified health facilities and community health centers. And so while at first sight that may not look like a tribal program, but it's actually very important to the way that healthcare is delivered in Indian country. We specifically work to advocate for building that trust relationship and providing education to individuals about all of the programs that we're working across, raising concerns that tribes are bringing forward in the policy space and a myriad of issues. That includes the Indian Health Service, that includes public health, healthcare coverage, as well as Native veterans health issues. We're also working across partisan lines to elevate tribes and the trust and treaty obligations. Indian health is a bipartisan issue, and it's an issue for all Americans. I think we can't underscore that enough. We're working to ensure that tribes are at the forefront of that policy decision process. And supporting that engagement. As I was describing, when we come together to bring tribal leaders in front of federal partners, we want to make sure that they have the support, whether that's in individual meetings or whether we're providing technical assistance as a part of any tribal technical advisory groups that we are working with. And we're also working very closely with members of Congress on tribal priorities, including budget and legislation. There are several committees that we work very closely with, specifically the Senate Committee on Indian Affairs, which is a dedicated committee to Indian Affairs issues in federal government. The House Natural Resources Committee, their subcommittee for Indian and Insular Affairs, is the House equivalent, dedicated to Indian issues. We also work extensively with the health-related committees, and so that includes the Senate Health, Education, Labor, and Pensions Committee, the Senate Finance Committee. We also work on the House side with Energy and Commerce, which is the health-facing committee, as well as Ways and Means, which has jurisdiction over Medicare. And then obviously we work very closely with the appropriations committees, who have jurisdiction over the Indian Health Service's primary budget. Part of the reason that we work to elevate very specifically the rights of consultation is that these are not rights that are to be neglected. These actually exist in statute, and to provide some examples of where those exist. For the Medicaid and CHIP programs, for example, under the American Reinvestment and Recovery Act, there are requirements that tribes be involved at the front end on Medicaid policy, particularly as it relates to the adoption of state plan amendments, waivers that might address the way that Medicaid interacts with tribal providers and their beneficiaries. The Indian Healthcare Improvement Act does require that HHS and the Indian Health Service engage in consultation related to the budget development process every year. And then Executive Order 13175, which discusses consultation broadly across the federal government, requiring consultation in instances when a policy will have tribal implications. And then finally, tribal issues don't just impact our communities. Those tribal issues impact non-tribal programs. In addition to impacting tribes, they also impact non-native individuals. In the communities where there are tribally operated clinics, for example, those facilities can elect to provide care directly to non-native individuals in their community to ensure that their full communities are receiving the care that is necessary for the health of their community. This is also true in the delivery of care for Native veterans. The Indian Health Service and tribal facilities offer care to Native veterans, but in some instances, those clinics are also open as an additional extension of the network for veterans at large. As for example, in Alaska, the clinics see veterans out in rural communities because there is no direct access to VA serving facilities. And so in that way, we're working to deliver care to entire populations in the communities that we live in. And then next slide. Just to tie in kind of what we're working on currently and some of our priorities that we're really focused on right now, ensuring that tribal consultation is happening as a part of any federal policy development or any federal policy changes that would have tribal implications. We want to make sure that we're honoring that trust and treaty obligation that exists not only in the Indian Health Service, but also at all HHS partners and across the federal government. Then we're working on protecting the Indian health system and Medicaid reform. There are very special protections for American Indian Alaska Natives within Medicaid and ACA, and we want to ensure that those are protected because they are part of how we meet the trust and treaty responsibilities through funding. And then preserving federal grants and programs in Indian country that are a part of that larger trust and treaty obligation. We're currently working to help get exemptions from reduction in force for tribal serving federal employees. Those individuals work to deliver the trust and treaty obligations to tribes and their citizens, and we want to make sure that those are not abridged. We are working to ensure that the Indian Health Service budget is available and fully funded, so that we're delivering the highest and best quality of care to our tribal citizens. And then finally, expanding self-governance. We know that self-governance provides an excellent opportunity to improve the quality of care that tribal citizens receive, and that tribes have the capacity to deliver excellent health care. And we want to see that expanded outside of the Indian Health Service to other HHS programs. And then with that, I will turn it over to Lacey, our Public Health and Policy Director.
Thank you, Wynn. Good afternoon, everybody. So we are the program side of NIHB, and today I'm going to kind of dig a little bit deeper into what AC talked about, kind of the current state, pull out some data, talk a little bit about our public health scan that we do, and then really end with what we are doing about and addressing the issues. So on our public health side, our program side, our vision statement is working together to empower sovereign tribal nations to improve equity, policy, and public health systems that build thriving Native communities now and forever for the next generation. Next slide. So the state of public health in Indian country, historically and ongoing challenges. We've had historic underfunding in IHS, like both WIND and AC talked about. Limited infrastructure and resources. And of course, historically, we've always had the impacts of colonization and systematic inequities. Some contemporary issues, we have high rates of chronic disease, behavioral health disparities, emergency response gaps, workforce shortages, and then COVID-19 gap really increased or decreased our life expectancy. Next slide. So here's just pulled out some data to kind of show the state of public health. So 5.5, we have a 5.5 lower life expectancy, and then our diabetes rate is 2.5 times higher for non-Hispanic and white. Our communities have the highest rate of suicide among youth ages 10 to 24. I also believe that that is 4 times higher than their peers. Chronic disease and underfunding and workforce gaps. IHS per capita is spending $4,078 compared to the general US that's spending $13,185. We only have 1% of our public health workforce that are American Indian and Alaska Natives. The Indian Health Service does offer some public health services, but it's limited, and a lot of times it falls upon the tribes to provide those services. Tribes have a variety of ways, because their sovereignty, to create their public health system. So they can have a formal public health departments, integrated healthcare, or public health. Next slide. So a lot of our communities are small, but they have mighty teams. Many of the professionals wear multiple hats. Public health systems are less cohesive, and we have to do a lot of patchwork. So a lot of times, the people that are doing the work are a variety of partnerships, including tribes, IHS, CDC, techs, and nonprofits. The biggest gap that we have is in specialty care training. So in our fixed data, what we saw, so our fixed data is our public health capacity scan. And what we saw were some opportunities to create bigger workforce development pipelines. We needed leadership support, and our tribes needed cross-training and mentorship. Next slide. So from our capacity scan, here's just kind of to show the workforce. A fourth of our public health departments did not have even one full-time staff member for their public health department. Next slide. So 21.5 increase needed positions of funding tribal health organizations. If you can see the red means that they need that position, but they're not able to fund it. The kind of the lighter red means that those positions, they have funding, but they are vacant. So if you can see how big the red is in underfunding, it's a huge amount. Next slide. So I did include also IHS staffing vacancies because, again, a lot of times dependent on the sovereignty, it could be a mix and match. So IHS has a 30% vacancy rate, including 36 of physicians, 44 of behavioral health providers is their vacancy rate. Next slide. So in our tribal public health capacity scan today in 2023, 85% of our tribal organizations did report, even though that they're small but mighty, are conducting some type of public health programming, and 60% plus are engaging in policy systems and environmental change strategies. So even though we're small, we're still getting some of our work done. Our strengths obviously are that the community is engaged because they know how to do the work the best. And so our tribal health organizations, their community is engaged with them. They are creating cultural integration, and their workforce is committed to doing the work. We'll see this but the biggest barrier that we're going to see on several slides is that the barrier is funding limitations and staff capacity, as we saw in the graphs on workforce, and then resource access. Next slide. So focus areas of tribal public health programs, their top issues were chronic disease prevention, behavioral health and substance use, emergency prepared and responsiveness, environmental health, and maternal and child health. The top public health needs, again, were staffing and funding. And in that staffing and funding, making sure that we are providing enough flexibility and enough staff that are American Indian Alaska Native so that we can really culturally ground our strategies across all the efforts. Next slide. So some needs and opportunities, like I said, we need greater funding and flexibility for tribes because they are sovereign and they know how to administer their services the best. We need investment in tribal-led data systems. A lot of our data and how we collect data is misrepresented due to how we identify and what our communities look like. Workforce development programs tailored to actually our American Indian Alaska Native communities. Of the 574 plus, they all look different. And so the workforce really needs to be developed by those communities, and the funding needs to be representing to that. We need to be supporting our tribal public health law and policy and development, and really, again, centering, this is kind of a focal point of centering Indigenous knowledge in all our systems. Next slide. So again, we are small but mighty, but in our capacity assessment, we did see that 88% of our tribal health organizations provide behavioral health services, and 70% of our tribal health organizations are engaging in COVID-19 recovery planning, infrastructure building, and emergency preparedness. So even though the workforce is small, the funding is small, we are still participating the best that we can with what we have. All of our tribes, all our 574 tribes are exercising sovereignty and how they define it and prioritize and deliver public health in the way that makes sense to them. NIHB supported last year, NIHB supported over 260 tribal public health projects across prevention, mental health policy, and data sovereignty. Next slide. So currently, this first quarter per staff, our staff was able to direct engage in tribes, 55 tribes. They were able to engage into 55 tribes. Each staff member was estimated that their organizations, that they were able to touch 66 national regional organizations across the PPH team. And then we were able to meet approximately 100 individuals. So each one of our staff were able to meet 100 each individual per quarter. And then our webinars reach about 100 participants per webinar. Next slide. These are the current projects that we are doing. As you can see, a lot of them reflect in the capacity scan, a lot of what tribal health departments are asking for. Next slide. Here are some reports that we have out for 2024-25. If you want to access them, please just go to our website and read our great research and reports. And then you can just skip that slide and we'll pass it on to Mario.
I will be Mario today. Good afternoon. Hello, I'm Rod Jacobs. Great to see you. Really excited to share about our National Tribal Health Conference taking place in Chandler, Arizona, at one of the beautiful properties on the Gila River community. Our theme is Culture is Medicine, Community is Healing. And that will take place September 7th to the 12th in Chandler, Arizona. Next slide. So we are, really looking forward to bringing over 1,500 tribal leaders, tribal health directors and administrators, public health staff, advocacy partners, industry experts are all making their way to Arizona this September to have some really in-depth conversations. We're going to have over 60 workshops. Next slide. I just shared a link in the chat around our conference, so you'll be able to take a look at some of the past consultations that we've had, what different speakers were involved. Right now we're in the midst of accepting proposals for our workshops, and we welcome you to join us as potential partners in this work. We have some sponsorship opportunities, and we'll share those in the next slide. Next one. So on our website, you'll be able to download our partnership prospectus if you or someone you know is looking to get more involved in the National Tribal Health Conference. We'd love to be able to have you there. Next slide. And the next slide. So this is kind of the last part, looking at the partnerships to pathways. And we want to leave you with a little bit of advice, suggestions to help moving forward. I know Lacey talked about how important and of having those resources. And so, when you're looking at engaging funders, one of the things that you should have is develop a philanthropy toolkit. It's a one-pager, has your mission, your unique approach, put some success stories on there. You can have specific asks, some funding tiers if available, as well as testimonials and some partner quotes. But ground that in Native sovereignty and strength, and really showcase who you are as a community, as a program, as a project, as an individual. Because what we really want to do is we want to be able to tell the story of tribal sovereignty and self-determination in healthcare. And you can do that through a lot of your tools that you have. So frame the health system as a leader in Indigenous innovation, not just as a recipient of a need-based aid. We want to highlight to funders our unique solutions to healthcare, We want to highlight some of those traditional healing practices that, alongside Western medicine, will help this holistic care. Also recommend leveraging philanthropic and funder networks. There are a number of Indigenous-led, Native American-led funder networks that you can participate at. There are a number of conferences and summits where you can connect with different funders. Our conference as well, we really encourage funders to attend, to learn, to network, and to engage in tribal health. We also want you to build authentic relationships with funders. Prioritize relationship first over proposal. Invite funders to community events, council meetings, cultural ceremonies when appropriate. Develop ambassadors within your community, both tribal leaders, youth, elders, who can help funders build trust and understand the values that you bring to tribal health. Next slide. So funders, when you're looking to fund tribal health, we want you to engage in authentic relationship building. Spend time in the community, listen, learn, and show up with humility. Avoid those extractive site visits. Come with the intent to build reciprocal relationships and not just evaluate. We ask you to understand tribes and the indigenous determinants of health. Let culture lead the way. Understand that many tribes, health is inseparable from land, language, family, ceremony, and spirit. Fund cultural practices, powwows, talking circles, traditional food sovereignty. Those are public health investments. And lastly, provide trust-based multi-year unrestricted funding. Fund for the long term. Commit to a multi-year partnership that builds trust and continuity. Provide unrestricted, flexible funding to allow tribes to define their own health goals and use funds in ways that reflect their systems of care, and support capacity building. Establish administrative and workforce infrastructure so tribes can sustainably scale their health programs. Now I'll turn it back over to our CEO, AC Locklear.
Thanks, Rod, and thanks everyone. I think it's time for us to kind of open up to some questions. I think we have a couple of minutes for that. If you have any specific questions, you can use the raised hand feature or drop them in the chat or the Q&A box. So there are a couple in the Q&A box, specifically around some of the advocacy the National Indian Health Board is doing right now. There are a couple here that I think we could probably answer together. This is around the RIF, reduction in force exemptions, as well as the restructuring across HHS. And just a little background on our work. We understand very, very well that there are many folks across HHS who are staffing programs who have a direct impact on Indian country and Indian programs who may not reside in Indian health services or within an Indian health office. We are working really closely with the agency and providing as much information as we can to highlight those examples. As we know, tribal nations often they receive funding from a variety of different places. And there are folks who are working to effectuate those programs and make them as successful as possible. So we are looking at that, and we are elevating those concerns as well as much as possible. Are there any additional questions? I know there were some questions in the chat. If you have a question in the chat, just drop your contact information if it was specific to a person, or if you'd like us to follow up with you, you could add it in there.
Yeah. And AC, do you mind if I add to that last response that you provided?
Go ahead.
So I know that we have a number of tribal folks on today, and I just want to put a plug in. So next Tuesday, 2 p.m. Eastern time, our government relations division is actually holding a tribal-only roundtable so that we can hear about the impacts that tribes are having right now as we prepare for additional engagement on the reorganization with the administration. And I would just encourage all of you to register for that. We do encourage tribal folks to attend that. And so that's part of the process that we're working through, is to create space for folks to come forward and share that in a confidential and privileged environment, so that we can carry those messages up to the administration.
Yes, thanks, Gwen. And when we say tribal, we do mean tribal organizations, tribally led organizations, tribal advocates, and TAs. We'll follow a tribal protocol and give tribal leaders the opportunity to speak first. This is not a space for federal partners. So we hope we see everyone there. There are many ways to get tribal orgs more involved. I saw someone in the chat mention. It really just depends. I think the first is to reach out to us here at NIHB, and we can talk about your capacity and what you want to get involved in. There are a variety of different projects on our public health side, as well as a variety of different ways to engage with our government relations team. On our website, there are various email addresses for all the folks in all the departments, and you can reach out there. With that said, we really want to thank everyone for joining us today. And we really want to emphasize the importance right now of elevating these tribal issues and capitalizing off the attention that is being given to us across the United States, and elevating our public health infrastructure to ensure that our tribes have everything they need going forward to be as healthy as possible. So thank you all for joining us today, and we hope to see you all soon.